spending your time with us this morning. We're really thrilled that all of the three previous speakers committed to sharing their wealth of knowledge with us, and we're extremely grateful for all of the panel members. So Dr. Tom Howard came back to sit up at the table, and he'll be willing to take questions. To his left is Rosemary Britz, who I'm happy to say has become a friend of mine. Previously it was a slightly different relationship as we took care of her daughter. But Rosemary's been a great partner in some of the work that we've been doing over the past few years. She's the executive director of the Sickle Cell Association community-based organization in St. Louis. She is the mother of a 22-year-old with sickle cell disease for her privacy, we won't name her, although most of us know her. Her daughter's in college and is doing extremely well. Rosemary truly has a passion and interest in education in the community about sickle cell disease and supporting the entire community. She's also a married mother of 5. She's pursuing her MBA, and she's active with a professional women's group and a member of her church choir because the other things weren't enough for her time. Next on the panel is Michael Johnson, who I affectionately refer to as MJ. Michael has also been fantastic to work with over the past God knows how many years, but he is fantastic. I originally met him in his capacity as chaplain to our sickle cell team, and by that I mean not only the families that we cared for with sickle cell, but also in large part to our team members. So Michael, like I said, is the chaplain for the team. He also is an adult living with sickle cell disease. He's been an advocate for many families and communities with sickle cell. He previously had demonstrated multiple years of leadership by serving as director of the Sickle Cell Sabbath program, which is a local blood donation program that we have, where he organized multiple churches in town who commit to having blood drives that also targets African Americans to try to donate on a regular basis for our patients who have stroke, and that's called the Charles Drew program. He sits on the board of the American Red Cross. He's also volunteered at our camp that we sort of have for children with sickle cell disease, and he's been instrumental in working with our local federally qualified health center as we've grown our community outreach to educate people about sickle cell disease and trait. Next in line is Timnika Reed, who is also a parent of 2 children with sickle cell disease. It's too bad we don't have slides and can't pull up their pictures. They're absolutely adorable. Ms. Reed has also been active in advocating not only for her children, but other children in the community. She's volunteered with a few of the organizations that have been in existence to help serve families with sickle cell disease. As an advocate, she's volunteered to make hot packs that have been given to families of the children with sickle cell disease. She's volunteered her time to give us feedback at the hospital to the providers as well as the hospital itself, and she always participates in our events that are organized in town. Last but not least is Rachel Williams, who is also a parent advocate, a mother of 4, 2 of whom have sickle cell disease. Those children are also equally adorable. She's been incredibly active in her kids' schools and has gone out of her way to educate every teacher, nurse, principal, and tutor of her children to not only explain the strengths, but also their needs as they relate to sickle cell disease. She's always active in our events that we have and raising awareness about sickle cell disease. She's also active in her church, and we're thrilled that she came here this morning to join us. The last half hour of this is going to be very casual, as I mentioned earlier, and we'd really like this to be kind of an open mic question and answer. Could evolve into more of a discussion depending on how many questions take place, so that we can try to ask people who have or have children with this chronic disease what their experience has been with regard to the health system, as well as any other resources that they've encountered or would like to see within the community. So if anyone has any questions to start it off, I'm happy to walk the mic out. If they're not, I have a few questions of my own. And if there are questions that aren't going to direct or pertain directly to our panel, for those of you who are on the team based at the hospital and in our lab, I know who you are, and I have questions planned for you too. So with that, I'll take a question from the audience if there is one. Good friend Talisa, who we can always count on. Talisa is a nurse educator at the hospital for sickle cell disease, but that doesn't really do her justice in what she really does for the team.
I have a question for the parents that have kids with sickle cell disease. Once your kids are in the hospital setting and they're discharged, I know there's probably fear of your kid going home and basically in pain. How do you think, or what type of views do you have that can occur with the hospital and the community where somebody can actually come into your home to help with those fears and to help decrease the readmission rate, that if your kid have to come back in because their disease is not basically controlled in the hospital setting? What type of view setting, or do you think it would be a great idea that we can expand or expound on that?
I think it'll be a great idea.
There's a button on each of the mics. There's a mic.
I believe it'll be a great idea. As far as having someone come to your home after the child is discharged, it will set back them going back constantly to the hospital. Even education-wise, if that person can also be helpful for them missing days out of school after they are discharged, that person can also help them with managing pain and helping them get their schoolwork back intact.
Rachel, at this time, how do you handle that?
How do I handle it? I just fall in line where it's missing. I will follow my pain management plan and follow the discharge orders that is given to me. And if I see anything that both the child that needs to go back to the hospital, I would do that, but I would do my part, keeping them from going back into the hospital.
Tamika?
Yes, I would like to add to that. Me, myself, I manage it in a way where, well, because I'm a stay-at-home mom, I have the advantage of just being there, you know. So say if Hakeem or Hanaya is discharged and say schoolwork is an issue, missing that, I pretty much will have the school or the teacher to email me school documents, and then I also access extra textbooks at the beginning of the school year. So I do pre-planning. You know, I don't wait till situations to occur. So when you have curriculum night at your kid's school and meet the teacher, it's a good idea to take advantage of those, you know, those things, because it gives you a chance to talk one-on-one with the teachers and the staff and to kind of educate and brief them over things your children will be going through emotionally, physically, and mentally. So if they're kind of out of themselves or, you know, just not being the norm, then they know how to assist or kind of have ideas on how to approach it. And so, but with the discharge situation, I pretty much, I don't know, I just pretty much take charge, and I just go off motherly instincts and the education that the hospital has given me, which the hospital really provides good educational pieces. And what all you don't know and you're not comfortable with, they are always available with questions and, you know, anything that you're missing or you think you're just not doing right or something may change, because children do change in their conditions. So nothing is always the same, you know, for as your planning goes, even with discharge or at-home care. And I would like to benefit from the at-home care because, you know, children are comfortable with their parents. And so sometimes there's a resistance because on medication comes emotional stress, you know, mood swings, and then with kids going into teenage mode, you know, teaching them the importance of medication and alternatives, you just want to make sure they're not relying on things more so than helping themselves and teaching them about themselves and their bodies and whether they're, what triggers, you know, each child is different. So I think that at-home care comes to play for my family with like just having a third party, you know, just to help kind of, you know, guide and be that extra hand to kind of steer the care along with myself. And it takes kind of a lot of stress off the household because caring for sick children can be stressful. But I mean, it's a joy in it too because you learn things you never learned and you gain strength. But with that, I just think it'll be a good thing. I really do because it just gives you somebody else you can rely on, if that makes any sense.
That's great. Are there any other questions right now from the audience? Melanie?
Hi, I'm the manager of clinical programs for a local managed Medicaid organization, and we're in the process of developing a sickle cell program for different Medicaid plans across the United States, and looking at developing educational material for patients with sickle cell, as well as for parents with children with sickle cell, and then an adolescent transitional program. And I'm looking at developing the educational materials. What kind of helpful tips or what information have you found the most useful that maybe we could, you know, include in some of our materials that's out there?
Rosemary, would you like to tackle that?
I think one of the large things is just the basic genetics of the disease. And so we find that even individuals that have the disease don't know the genetics of it. They don't know how they can potentially pass that on in giving birth to a child if they have a mate that also has the trait. So I think a lot of the genetics would be important in educating people about sickle cell.
Tom?
I would offer, if you're interested, we have developed this baby step program, which is already a package. And you're welcome to look at that if it's of value to you.
So at Children's Hospital, we've been pretty successful with the infant toddler program and getting all the kids in who are identified by the state of Missouri newborn screening with disease and getting them started on penicillin, like Tom mentioned, and doing parent education so that we can try to help the parents better understand the inheritance of the disease. But our next challenge that we've finally decided to tackle is trying to educate the adolescents as they become childbearing age. Those particularly with disease because they're in our clinic, but we're also currently working on outreach and education with regard to trait, and one of our graduate students in the audience, Ashley Houston, is working on that as part of her project. Michael Johnson.
How's it going?
I was wondering if you could share your thoughts that you may have had as you heard Peter's talk about the synthesis of healthcare reform and how you may have seen some of these things already play out in your own experience in the medical system, and any hopes that you might have if these changes actually go into place.
Thank you. Very educational, very timely in that I've been on all sides of the healthcare issue. I'm a civil rights baby, so I've been in a situation where I've been told I wasn't going to be here past the age of 25 years old. And having sought out adult care was very difficult. I actually had an adult care doctor to tell me at the age of 24 that he was not trained properly to treat me in sickle cell because, and he admitted that medical schools that he had attended don't expect life expectancy beyond mid to late 20s, and therefore he was not trained properly. And I appreciated his honesty. In terms of healthcare reform, I recently did something that I reluctantly did, I was kind of forced to do, and that is file for a disability. Was approved in February of 2011. Was totally unaware that you get a pittance, a very small amount of money per month, and Medicaid had the mitigated gall to send me a letter, and they still send me letters monthly telling me I had a $2,200 spend down. So that means that you have to spend $2,200 in order to have Medicaid take care of any doctor visits, wellness care, those types of things. And doctors who had to treat me in October, I had not had a crisis serious enough to go into the hospital since 2009, and had to go in October of 2011, basically unconscious. But the doctors who treated me warned me prior to that onset that it was easier for them to hospitalize me through the emergency room first, then be admitted, because then Medicaid would kick in to pay for my hospitalization and my treatment. They also warned me that if a doctor tried to discharge me prior to the 30th of the month, because that was the first time I had to go home with home health care, that they would politically leverage themselves to make sure I didn't get out of the hospital till the 1st or 2nd of the month. So I was very amazed at the bureaucracy and the politics that was played at that time. In the meantime, I have finally qualified for Medicare. One thing they don't tell you when you apply initially, well, most people are not told, that there's a 24-month waiting period whereby you are uninsured. So for 24 months, you're depending on Medicaid if you can afford the spend down, because Medicare, unless you are a dialysis patient or have what's called Lou Gehrig's disease, you are pretty much on your own, out of pocket. That shocked me. I was incensed to the point where, thank God I had a mother who insisted that you do what the doctor calls self-management. And I irritated Social Security and Medicare to the point that the gentleman finally told me after my 200 or 300 call that actually you qualify for Medicare retroactively to the date you would have qualified for disability. I would have qualified for disability in 2010, in February of 2010. And so I only had to wait another 5 or 6 months instead of the full 24. But if I hadn't asked those questions, I would have been under the impression that I had to wait unless they just sent me information saying on this date it kicks in. So I was very fortunate and blessed in that sense. So I'm looking forward to the healthcare reforms that hopefully the current presidential administration has put forward. The information that was received here today, I think, will be beneficial to a lot of chronically ill and other types of patients, because as I get into my senior years, there's going to be a time where I'm going to need that home health care. I can tell that from my last visit to the hospital, and greatly appreciate the opportunity that you've offered here today through this particular forum, whereby the information that was received on healthcare reform was very beneficial. Allison, just quickly, I want to thank the team for the opportunity. I've been able to collaborate with the sickle cell team for the last 10 years. Dr. Michael DeMond and Dr. Allison King are the only 2 people in the world now that I've been forced into retirement. They can get me up this early in the morning. I don't move until the view comes on. But anyway, I want to thank the organization for accepting a collaboration with the Prince Hall Masons, and I'm glad to see some of these young men here today, as well as one of our sisters, Sister Johnson, who's sitting right up here in front from our Eastern Star chapter. And the Prince Hall Masons have been partners with St. Louis Children's Hospital in this HRSA grant in the MONET program for the last 4 years. So just raise your hands, gentlemen and lady, and thank you very much for participating.
Fantastic. Thank you, Michael.
Hi, this is directed at Michael Johnson. I've been donating blood for quite a while. And 2010, I just found out about the Charles Drew, which I switched over. Why isn't it more advertised?
Excellent. The Charles Drew program here in St. Louis is now 13 years old. It was founded in 1999 through the American Red Cross and collaboration with other partners such as community-based agencies and churches. One of the reasons is not what you may consider well publicized. It's like with anything like sickle cell. This room should be full today. Sickle cell disease in 1972, 40 years ago, was declared by Richard Milhouse Nixon as September being National Sickle Cell Awareness Month. Since that time, I'm sure you've heard of HIV and AIDS, which took precedence during the Reagan administration. That kind of set sickle cell back, in my opinion, quite a bit because of the energies and monies, because of the populations that HIV impacted and so forth. Sickle cell you didn't hear a whole lot about during those times. It wasn't until really late 90s, early part of 2000 that sickle cell became an awareness issue once again. Some of that in part here in Missouri because of the work of Jim Talent, who was senator at the time around 2001, 2002, and Democrat gentleman in New York who is still in office, Chuck Schumer, passed a bill called the Sickle Cell Disease Act of 2003. And so, just like with sickle cell, the Charles Drew program is suffering from lack of awareness. Historically, African Americans do not donate anything that comes from their body, whether it be an organ, an eye. We just have this fear, and fortunately, as the years have gone on, some of the myths have disappeared that came about as a result of the Tuskegee experiment or African Americans, Latino, and other populations being mistreated in the healthcare system as guinea pigs, if you will, for lack of a better term. And so we're just now in a position where we're educating persons of color, through church groups and faith-based organizations like Sickle Cell Salvage, the Charles Drew program, not just here in Missouri, but in other parts of the country, the importance of donating blood to persons who have, first of all, suffered either overt or what we call silent strokes who have sickle cell, and just donating period for accident victims, for persons who need surgeries, what have you. I've had 3 transfusions this year, which is phenomenal for me. I didn't start getting transfusions until 2002 when I started working with Allison King. Y'all didn't catch that, but anyway. In 2002, I started working with the sickle cell team. That was my first transfusion. And I've had one annually since. However, this year I've had 3, and the reason for that is you build up antibodies. And so it becomes harder for them to find a match for me because of the antibodies. And recently my doctor found out that the antibodies are coming from me. He thought it was from the outside blood, but my red blood cells are destroying my own red blood cells. And so fortunately, he's put me on another prescription that has helped fight that. But the Charles Drew program will grow, not just here in Missouri, but nationally, as I feel as time goes on. But we need people like you to continue educating folks to donate and keep that name Charles Drew out there. When you go donate, you have to ask for the Charles Drew program, or they'll just direct you into the general blood population. So you must ask to donate to the Charles Drew program. Thank you for the question.
MJ, before you finish, for those of you in the audience, or for those in the audience who aren't familiar with who Charles Drew is, could you give them a brief
The program
history?
is named after a medical doctor by the name of Charles Drew, who made it possible to separate plasma from red blood cells, from white blood cells during the war period, World War II in particular, to save lives on the battlefield, and discovered that blood banking was possible to keep blood for a period of time. And Dr. Drew was phenomenal. He was one of the first blood medical directors with the Red Cross, did an excellent blood program, and unfortunately was killed in an automobile accident. People assumed he was killed because of his color and couldn't get proper care at the hospital. That's not true. He got the best care possible. It's just that the injuries from the accident eventually took his life. But that's who is named after Dr. Charles Drew.
Is there anyone else who had a question? Joyce?
Hi, I'm wondering if you guys could speak a little bit about the challenge and helpful aspects of not only transitioning to adult care, but also adulthood for those who have personal experience with it, for helping your child transition.
Well, for me, I have, like I said, a 22-year-old daughter that has sickle cell disease SS, And it's been quite a challenge. We're working on the transition from children's care to adult care, and she's holding on tooth and nail to keep from moving over. And part of the problem for her is the ER care. And so when she goes into an acute crisis pain episode and she can't get the same care at other hospitals as she does at the children's hospital for whatever reason, and she's been told all kinds of things like, we don't treat sickle cell here, or we don't believe you're in a pain episode, or something to that effect. And so she doesn't get the same care. And so recently she's been hanging out at the hospital near her college, and they don't really have the expertise to treat sickle cell and some other things that she has going on. And I repeatedly asked them to seek the advice of St. Louis Children's Hospital's experts, and but they're like, oh, we know what we're doing, and ultimately she's ended up here in St. Louis receiving the care. So out of other adults that I've been talking to, it is the adult ER care that they're afraid of. A lot of them will sit at home in pain till the last moment because they don't want to seek care elsewhere.
Tom, as somebody who's been in the field for a little while and has a good thought process about where things should go in the future, how do you think that healthcare reform is going to hopefully help adults, young adults and older adults with this chronic disease?
Whenever we talk about developing care, and I hate to say this, but we did not have enough staff or enough organization at first, so we simply took the newborn screening kids and grew up with them. When there were 13-year-olds and I had under 5-year-olds to take care of, I focused on the under 5-year-olds. And as they grew up, I maintained the care and tried to develop the things that were necessary for them. The reason is because we didn't have enough resources. I don't know whether we are training enough people who have the will or the savvy, really, to take care of our adult sickle cell patients. I mean, that's been a goal for some time, but we're not really turning out people who have expertise. And one of the challenges for that in the medical world is it's very difficult to make that a focus of your career, because you're at the risk of Medicaid funding and everything else, predominantly. And academically, people tend to get separated aside, and they struggle to develop their careers if they focus on sickle cell disease only. Part of that has to do with NIH funding. It's available these days, as well as funding through Medicaid and other third-party payers. So I would think that one of the big focuses would be on the youngest of people, 22-year-olds, and trying to empower them. And I don't mean in saying this to forget you. I mean, but the truth of the matter is I don't think that we can bring to bear enough resources suddenly enough to deal with the numbers of persons who are aging up with sickle cell disease right now. We age up 50 patients a year. 50 patients a year. And you say, well, that's not too many. That's a lot of patients to help organize themselves to be ready for care, to identify a primary care doc. Now, the things that have been discussed with the ACA, I think they can help. But I think we have to focus on what we're going to take on. And my sense of things is, if I had to focus, I would focus on, I keep trying to tell the folks in my local community, focus on helping those people who have hit the age of transition to really be ready to go and to adapt and deal with them. And and do everything we can to help the persons who are older to grow up with this population. Because this population is the product and the beneficiary of newborn screening, which has actually been one of the major things that has organized all of this going forward. And now in most states, those persons are between 20 and 28 years of age, depending upon when your newborn screening program started. The latest on federal mandate was 1988, which would make the last programs, and that includes Alabama, to start newborn screening in 1988. So those folks are now 24 years old. So I think the focus on the youngest of patients will allow us to have enough resources, both financial, as well as trained and capable people, to really do the best job. And I think we need to do the very best we can with everyone else. But if we don't focus, we're going to end up diffused and not productive.
Mrs. Uza is one of our nurses at the local FQHC who works with us.
And my question is actually going back to the blood donation. And it's a question of this. Can somebody who has a sickle cell trait donate blood? And if he or she can, what is the education that we can give to that person?
Also, you know the answer to that. I will tell you, when it comes to chronic transfusion programs, we specify when we're transfusing persons with sickle cell disease that the blood be sickle cell, be trait negative. But I do not know that anybody who has sickle cell trait is excluded from donating. I'm not sure. Do you know, Allison?
People with trait are not excluded from donating in general, but I'm not sure about the Drew program.
Well, one point.
Oh wait, Catherine tells me she knows.
I spoke to Terry and Lindsay, who's our nurse practitioners. A lot of the families that I see the parents of children with disease, and they've been very anxious to know about whether they can donate to their own children, and they can't. So people with trait are eligible to donate, just not to somebody with disease.
One thing that is true amongst African American donors in general is there's a high prevalence of thalassemia minor, of the alpha variation, and when they check your blood count and your MCV is low, oftentimes they exclude you from donation. The frequency of alpha minor in persons of color is higher than it is in the rest of the population. So it may be that you'll be excluded for other reasons other than sickle cell trait. Okay.
And just to follow up on what the doctor is saying about that thalassemia, the assumption is that sickle cell affects only African Americans, especially since we're exposed to it here in the United States, and that is not true. Anyone who lives in warm climates where mosquitoes are prevalent, where malaria is prevalent, sickle cell trait serves as a defense mechanism against malaria, where sickle cell disease does not. And so the name thalassemia is used in some countries, in some areas, and not called sickle cell. So the assumption is there's more persons in the United States, and of course, due to the slave trade and the Atlantic slave movement, more Africans were brought to this country, and that's how sickle cell became so prevalent in the United States. But the Caribbean, the coast of Africa, the Mediterranean, parts of Italy, some parts of Asia, where malaria is prevalent, you also have the same disease, but it's called thalassemia or some other blood name as opposed to sickle cell.
So there are certain changes in the proteins of the way that we make blood that can create abnormal hemoglobin, and some of them create a sickle-specific trait, and some are thal-specific trait. So you can have a sickle and a thal and still have sickle cell disease. You can have a sickle and have sickle cell anemia, or you could have thal and have thalassemia, which is also a hemoglobinopathy. But I think that there are locale-specific jargons that are used to describe these types of hemoglobinopathies. Did anyone else from the, sorry.
Hello, my name is Elizabeth Brown, and I work with Melanie on clinical programs, and as she mentioned, we're in the process of putting together a sickle cell program across the nation. One of our intervention methods for our population is to increase the use of hydroxyurea, and right now we're running at about 50% usage rate. And so I guess my question is, what are some suggestions that would increase that usage for that population? What are some barriers as to why that, you know, what are your thoughts on that?
Okay. Yeah, anyway. Hydroxyurea. I was in the clinical trials in 1990 for hydroxyurea. The advantage for me was I was averaging 3 to 6 hospitalizations a year. And one year in 1991 went in 13 times with sickle cell crisis during that course of that year. So my doctor convinced me to go into clinical trials, and finally convinced me to start on hydroxyurea, which reduced my number of pain episodes in half. I was averaging 2 to 3 times a year after I started it. However, the disadvantage for me was once I turned a certain age, the hydroxyurea began to play against my immune system. And you develop, most sickle cell patients, not all of them, will develop ankle ulcers or leg ulcers. And since 1984, I've developed ankle ulcers, and the hydroxyurea slows the healing process tremendously. So I had to stop taking hydroxyurea around 2004. And having been put back on it, but fortunately I've only had on average 1 hospitalization a year. But the advantages, I think, just from watching the program that I was with the St. Louis Children's Hospital is the reduction in pain episodes on the condition the child understands that it's not a savior. You have to maintain a good diet and all the other things that the doctor and nurses recommend in order for the hydroxyurea to work.
Any other questions from the audience? All right, well, I think that will conclude our program. Thank you again to all of the panel. It's fantastic for you to share your stories.